We have, start over. Okay, hi, this is Dr. McMakin. I'm really excited to have everybody here. We have over 200 people signed up for this webinar, and it's a great way for us to keep in touch and to catch up and sort of share insights. It's a lot easier than coming to a core seminar, and it's more often than the advanced. So the way I've been doing these the last time and this time is to share something that happened to me recently that just is a practical day-to-day exercise in frequency-specific microcurrent. The frequencies are fairly straightforward. The challenge is how to think about the diagnosis and how to think about the application. So this is going to be not numbers, but thought processes. So, oh shit.
Can you just click on
present to everyone?
You're already doing that.
Okay. The first patient I treated yesterday was a 45-year-old male. He had an 18-year history. He's in his 40s. His first episode of ulcerative colitis was about 18 years ago. It started with antibiotic use, so he took Cipro for something, I think a respiratory infection, and that led to 20 bowel movements a day. He lost a bunch of weight, had bleeding, diagnosed as ulcerative colitis. His dad was a homeopath, so he kind of refused the standard medical approach, treated himself, and got himself into remission on his own. Probiotics, diet, food, allergen avoidance, and got himself into remission. 3 years ago, he took a course of Levaquin as part of a medical therapy that was prescribed, and that started the flare-up again. He was doing 20 bowel movements a day with bleeding at every bowel movement, bloating, pain, weight loss. He lost 35 pounds. That time, the symptoms were very much the same as his ulcerative colitis, but a colonoscopy and biopsy diagnosed him as having Crohn's. So, being the son of a homeopath, he refused Asacol, he refused steroids, he refused traditional medical therapy and started treating himself again. And he connected with a naturopathic physician at SCNM, and that has decreased his symptoms. He's put back on about 30 pounds, so he's back up to 185. Hypoallergenic diet, probiotics, specific supplements to help rebuild the gut wall. And what's interesting about the probiotics is he has to be careful. If he takes too many of the probiotics, he gets diarrhea. If he gets it just right, his diarrhea is better. It goes back down to about 10. And he considers 10 acceptable. These days, he has only bleeding at the end of the day. So in the morning, he'll have loose bowel movements, but there's no bleeding with them. His weight's back up to normal, and he's fairly stoic after all this. And so when he laid down on the table, he had no subjective pain. He looks healthy. Skin tone is good. Fingernails are good. Eyebrows he has no other autoimmune symptoms, no other autoimmune diagnoses that we know about. However, when you palpated his abdomen, when I palpated his abdomen, there was pain and guarding in the left lower quadrant, like over where you'd think the sigmoid would be. And then as you head down to the suprapubic area, when you palpate just above the pubic bone and aim your fingers downward towards the rectum, in a male, that's going to compress the rectum. And that was exquisitely tender. His sigmoid was exquisitely tender. The left upper quadrant along the line of the transverse colon was tight, so increased tone and some guarding. Not exquisitely tender. It was like a +2 or a 3. It was like, ow, I'd rather you not do that. The left upper quadrant was tender there. And then when you palpated the right, he was all right until you got down to the appendix and the ileocecal area. That was tender, slightly tender, some motor guarding. And then centrally in the periumbilical area, over what I think of as the small intestine, he had guarding and some tenderness, so like a +1 or a +2 tender, not horribly tender. So ulcerative colitis and Crohn's are his diagnosis. They don't seem to be able to decide which one it is, but either way, it's about the same. Frequencies are going to be easy. They're frequencies you got in the core seminar, maybe a couple from the advanced, but it's the thought process that's the focus of this case. I had 2 machines in one set of contacts. So I have 2 graphite gloves in the towel that's under his low back, and 2 graphite gloves in the towel that's over the lower abdomen. This photograph is a female patient in a leotard, so obviously he had his skin exposed, his trousers were unzipped the top inch or so. We covered him up with a blanket, nice warm contacts down on the abdomen. I had a Precision Care and an Auto Care 1300. I probably could have used a Custom Care instead of the Auto Care, but the Precision Care was actually essential to this case. In the Auto Care, we ran, of course, the concussion protocol first, in part because the medulla regulates the vagus nerve, and the vagus nerve regulates the gut. So we ran the concussion protocol first, and then that ran, 34 minutes? And then we ran emotional relax and balance. The whole treatment time was 60 minutes. So then I had the Precision Care for treating the colon. So the frequency choices that I made were based on his history and based on what was most likely to change his symptoms. So the symptoms I wanted to change were abdominal muscle tone. It was rigid over the areas that were tender. So I don't know that you'd call it rigidity so much as you would call it guarding, right? And then the pain on palpation, he would flinch and move away from your fingers. It was quite tender, especially in the sigmoid and rectum area, which is to be expected when he's bleeding. Let's say with 5 bowel movements, the blood is red, it's not black, so it's local, it's peripheral towards the end of the colon, doesn't have time to coagulate or form clots, it's bright red. So his left lower quadrant and the suprapubic area were tight, very tender and rigid. Relevant history, like I said, was bleeding with bowel movements. The characteristic for bleeding, right? When you go to treat somebody that has a brand new injury, the pain is bothersome. It's blood outside of blood vessels stimulates class C pain fibers, and it creates, those are slow multimodal fibers that creates diffuse aching that, and this patient's fairly stoic, so he didn't report a lot of pain because having dealt with this on and off for 3 years, this exacerbation for 3 years, and the kind of pain or aching he would have if you had to pin him down and get him to a mid-2, it probably would have been a 2 or a 3, but it wasn't anything he would complain about. The pain on palpation was characteristic. It was bothersome, and it was the superficial tissue was very tender and it was rigid. So the first frequency I ran on the Precision Care was 18 and 62. Now this slide says it ran for 20 minutes. That's probably a little bit of an exaggeration. The first time I ran it was probably 10 minutes. And what happened was an immediate softening. The slide says abdominal tissue, but it was the left lower quadrant and the rectum that changed. I didn't run the frequencies for the sigmoid 129 or the rectum, but it was only those two areas where 18 and 62 softened the abdominal tissue. We reduced the pain on palpation. He got all squishy. He stopped blinking. So the naturopath that I was working with had never seen that before. He hadn't seen FSM used before. So the patient's talking to us, and then all of a sudden his blink rate goes from, what is it, usually 20 a minute or so. He just stopped blinking, and then he stopped talking. So that I had to explain, or got to explain, the concept of DORF, which was pretty fun. So the patient, we didn't use the word stoned with him. We used the word floaty. He could do floaty and kind of an induced euphoria. It was just felt really good, and he felt very relaxed. But so first we stopped the bleeding. And just as a reminder, the small intestine frequency is 22. Colon as a whole is 85, and for whatever reason I didn't use that. Cecum is 3, ascending colon is 31. Transverse colon is 27 and 16, and we use those ultimately to deal with the left upper quadrant and the transverse tightness. Descending colon is 65. Sigmoid was 129, rectum is 88. Sympathetics and parasympathetics, he was not particularly sympathetically driven, but I think I ran 40 and 562 just for a minute or two, and it had no effect, so I moved right off of it. So here's the thing. His history, the ulcerative colitis and the Crohn's, started with antibiotic use. Okay, so you kill off the healthy bacteria with an overdose of antibiotics and with not enough probiotics. The appropriate bacteria that you need die, and the bacteria that you need to produce short-chain fatty acids and the other substances that heal your gut wall, those bacteria go away. So the stool test was negative for parasites, but they hadn't done DNA testing. And he had, his stool testing did not have pathogens. So we knew he didn't have C. diff. We knew he didn't have other pathogens. But because it began with dysbiosis, I didn't use 40 for almost an hour. I ran it in the last 10 minutes, I think, but I didn't use 40. What I did use was pus and pus encapsulated, right? Why? Okay, let's go back to this question. Why wouldn't I use 40? Well, I didn't use 40 because of the concern about infectious agents. It's like, what is actually causing his problem? Is it primarily inflammatory? Is it primarily inflammation? Is it an autoimmune condition? Not so much. It started with dysbiosis. So what would you use? I used 64 and 42, 64 and 63, the Abrams frequencies for pus and pus encapsulated. And I actually expected to kind of blow right through those, and I didn't. They started softening his belly. He completely stopped talking and closed his eyes. And they probably ran 5 or 6 minutes a piece. I thought that was interesting. That led me, of course, to 9740 and 9820, putrefactive and fermentative toxin, right? All 4 of these are Abrams frequencies. And once again, his belly got warm, he got stoned, and those ran for a shorter period of time, like 2 or 3 minutes a piece. So how do you assess what you use and for how long? His pain was going down, becoming less tender, and my fingers were basically, the flat fingers in my hand were sort of roaming his abdomen, right? Lower left quadrant was good after we stopped the bleeding. It responded really well. The pus and pus encapsulated, roaming his abdomen. These 4 frequencies took out everything except the tightness over the left upper quadrant and the tightness down in the cecum appendix area. The concern about antibiotic use brought us to 460 and 650. I think that's the frequency for Candida toxin. Let me put that in. I think you're seeing these in real time. And that ran for just a minute or two, but it took down the tenderness in the periumbilical area. So that suggested that the candidal overgrowth was more of a problem in his small bowel for some reason, or I have no idea. All I know is that Candida toxin took down the tenderness around his umbilicus and made his small bowel a little less tender to palpate. Dysbiosis, 44 is the frequency for E. coli, and 61 is the general frequency for infection. So I ran both of those with the colon parts, right? The sigmoid 129, rectum didn't do much. Descending colon was 65, transverse colon 16 seemed to help, 27 didn't do much. 22, the small bowel, that seemed to do much. And then by then, the whole left side of his abdomen was really soft and non-tender, like smushy. And what stood out was the right lower quadrant, which hadn't been tight by comparison before. And at that point, I asked him if he had his appendix still. He said yes. So I added the frequency for his appendix. So I did 129, the sigmoid, 65, the descending, 27 and 16. 31 didn't do much. 3 was okay, but 68 is the frequency for the appendix. And 61 in the appendix softened that lower right quadrant. 44, I ran it in all the digestive system parts, and that didn't seem to do a whole lot. But it was worth a try. Not everything you try is going to bear fruit or have a profound response. So tissue softening was the response to the frequencies. The patient got really quiet. So that was the dysbiosis part of it. Now, we all know that ulcerative colitis and Crohn's are inflammatory. But is that the first thing you want to treat if you've just treated for dysbiosis or bacteria? I didn't want to do that. I put 40 off to the very end. So 124. What's wrong in ulcerative colitis? Well, it's ulcerative, 150 and 650, but it didn't do anything. It didn't do much, which surprised me. 124, once again, he got really quiet. He got pretty stoned, stopped blinking, closed his eyes, and I ran 124 with the sigmoid. The rectum, 88, so sigmoid's 129, 88's the rectum, 65's the descending. The numbers aren't so important as the idea of 124, torn and broken. There's too many colon parts to run. 294 through 21 and 9 on everything. So I think I ran 294, trauma paralysis allergy reaction, with the sigmoid and the rectum, the two that were the kind of the hottest to start with. Ulceration, which is a surprise, gave no response. What's interesting is when I got to allergy reaction, I thought that histamine would be a winner, that it would take the small bowel tenderness that remained, it would do that. It did absolutely nothing. Not much anyway, a little bit, 5%, little teeny bit of improvement in the small intestine, not even much in the large bowel at all. So then it was finally time. We were on about 50 minutes now. So I switched from the concussion protocol and the autocare to emotional relax and balance, and ran inflammation in the colon part. So I think I started with the rectum, and that did okay. That was nice, softened that area, 129. Hand got warm on his abdomen, so I'm working under the towel and around the towel with my hand on his skin. 129 softened up. 27 and 16, the transverse softened up. 22, the small bowel area, that softened up. However, it made the left lower quadrant like over the sigmoid. So after it softened everything, it made the left lower quadrant tighter. That made me a little nervous. So I went back to 64 and 42, 64 and 63, pus and pus encapsulated, and that softened up that left lower quadrant, the sigmoid area, I think, even more. So it was screaming success. It was lovely. Then I ran vitality in the parts. Now, in terms of follow-up, what does the frequency response tell us? Well, at the end of it, he was very happy, stood up straighter, completely pain-free to palpation. Abdomen was soft and non-tender. He's going to see his naturopath in a week. Continue with the supplements and the diet. Now, the response to 40 in the sigmoid suggests there's still something going on in terms of dysbiosis, right? Why the sigmoid? Why 64 and 42? Fermentative and putrefactive toxin didn't do anything. But so it suggests that something like Saccharomyces perhaps would be useful. It kills C. diff. He doesn't have C. diff, but there's still some sort of bug there. If the frequency response is correct, there's some sort of bug in his sigmoid and his descending colon. So that would tell me, if I was his treating physician, that yes, stay on the supplements that are helping your gut. Things are coming along fine. Stay on the hypoallergenic diet. But I might be tempted to add, you can't add additional probiotics or that gives him diarrhea, but it would be worthwhile, it seems, to add something like Saccharomyces or grapefruit seed extract to his situation. And I think he's taking GSE already, but he had been off of it for a couple of weeks, and they decided that they'd add that back for a week or two and see if that changed his symptoms and got things to hold better. Now, treating him was easy because he was already doing all of the stable state things. He already had the hypoallergenic diet. He already had the gut repair supplements. It was quite a comprehensive mixture. I don't remember the name of the product, actually. But he already had that stable state. All we had to do was get the signaling in the colon and the digestive system turned around. I do believe I ran 40 and 116. I think I ran 94 and 116 now that I think of it, because when I said he didn't have any other autoimmune conditions, I lied. He has vitiligo. So if I was there to follow up again, the next time I would treat the immune system, right, for 94, 321, 9, 40, and 116. Once you get the dysbiosis taken care of in the gut, then you can really go after the immune system to shut it off and maybe keep the vitiligo from spreading. So that was that patient. It was really fun. My private practice up here is very small, and so it was really fun to have this patient as a case to talk to you about. If you have any questions, are we able to see those? Yeah. Okay. If you have any questions, send them in, and we'll keep an eye on the intake. The second patient was a family member of one of the doctors at the clinic, and this was her history. We were supposed to have treated her for endometriosis and abdominal scarring, and instead, 24 hours before, so like I treated on Thursday morning, so on Wednesday afternoon, she was moving some things in the home. She was bent forward at the waist, moving some items on the shelf, and it dislodged I think it was a picture frame with a metal edge. So it probably weighed, 5 pounds, maybe 7 pounds. and it fell off as she's bent forward at the waist. It fell off the shelf above her. So it was 1 to 2 feet above her, 5 pounds, and landed crossways on her neck at C5, 6, and 7. So there was actually a small laceration on the skin at about the 5, 6 disc level. Okay, she's 37 years old, history of endometriosis, but she had no prior spine injuries, no history of neck or back pain, no history of auto accidents. So nothing much in the way of previous stuff that would be complicated by this mechanism of injury. Pay attention to the mechanism of injury because it determines what the treatment is, okay? Back of the neck is going to put her neck in extension, but it's also going to put a tremendous force right through the 5, 6, 6, 7 discs, okay? So being a good naturopathic patient, she applied arnica, ice, and took an herbal anti-inflammatory. So that was the home care the night before. By the time I saw her on Thursday morning, she had a headache up the back of her head that she rated about a 3, 5, 4. She had neck and shoulder pain. She rated at a 5 or so. Mid-scapular pain, the pain in between her shoulder blades was really bothersome. So neck and shoulder pain was listed as a 5 or 6 out of 10. Mid-scapular pain was a 5 or 6 out of 10. She was antalgic, walking very carefully and stiffly, not using her arms. Her head was forward. And this headache was associated with this cognitive dysfunction. She looked disoriented. Her skin color was not good. She looked like she was in pain. And then on top of this, she had left-sided low back pain at about L5S1 that she rated about a 3 or 4, aching, and worse was certain movement. So physical exam, she had very hyperactive patellar reflexes, which tells you what? It tells you that disc bulge has happened. She had no prior history of neck injuries, so it's likely that this was acute. You get hyperactive patellar reflexes when you get slowed descending inhibition of descending inhibitory impulses in the spinal cord, and they can't get to the L3 level fast enough to inhibit the reflexes. So the hyperactive patellar reflexes said that she was, that her spinal cord was inflamed, and this points us to a disc. Sensory exam, normal for sharp. She didn't have any complaints of arm pain, hand pain, thumb pain, no hyperesthesia or numbness, no tingling that she complained about. She did have pain in her left leg. Just one episode of a sharp, stingy sort of pain down her left leg the previous night. Cranial nerves were normal. Her facial movements were normal. Her tongue movement was normal. She could blink, raise her eyebrows, look from side to side, stick her tongue out. That was all normal. The neck muscles were quite tight and very tender. So I call that a +3 out of 4 because you could touch it, but it was quite tender. And tender enough that you couldn't actually palpate the spinous processes. Cervical range of motion was reduced by about 30%. So she could rotate to like 40 degrees, couldn't turn her head easily, could bend her neck forward, but only by about 30 or 40 degrees. So it was reduced by 30 to 40%, quite antalgic and painful when she moved. What's interesting, even though her major complaint was mid-scapular pain, her mid-scapular muscles were tight, but they weren't tender. They didn't hurt when I palpated them. She didn't have any ribs that were subluxated. When I finally was able to palpate the spinous process at C5, 6, 7, it was very tender to very light palpation, but it was only after about 30 or 40 minutes worth of treatment that I was able to even touch the spinous process. The muscles were so tight, I couldn't get to it, and her whole neck was so tight, it was hard to tell what exactly was going to be sore because the muscles were so tight. And then lumbar exam, facet compression at L5S1, L4-5 to some extent. Those were strongly positive. Not enough to suggest that the SI joint was torn or compromised, but just the 4-5 and 5S1 facets were sore on compression. So look at the mechanism of injury, okay? Here's where we are. So this mirror, or this picture frame, landed crossways on her neck, right about this level, okay? So she's about C5 or so down here. So look at the tissues, connective tissue, muscle, the upper trap. The little laceration was right there. It was just a red mark. The skin wasn't split, but it was cut. It had already sort of healed. And this is the architecture below. So if you think about, see 1, 2, 3, 4, 5, 6, if you think about this picture frame landing on the spinous process of C6, this is the force vector that goes through here, okay? So that told me what I wanted to do, was looking at the mechanism of injury. The mid-scapular pain tells you what? Remember that diagram from Cloward where the discs refer pain in between the shoulder blades. So she didn't have tight muscles in between her shoulder blades, but she had pain in between her shoulder blades, which points me to the disc, right? I think of the disc annulus being injured when you have mid-scapular pain. So that's what's going to explain the course of treatment that I tried in the next slide. I had 2 machines, an AutoCare that I put on her low back and abdomen, and just 1 glove from the AutoCare on the low back and on the abdomen. And then the Precision Care was set up with the posterior neck and chest. And for those of you that are wondering, every time I travel with 1 suitcase that has my 2 pillows in it. And it also has my Precision Care and an AutoCare 1300. I don't ever travel without them. Even if I'm going not for a seminar, I always take them with me. And that's so I can do what I want to do when I need to do it. So I had the posterior neck and the chest set up pretty much like this. This one was folded in half and sort of stuffed down between her bra. We had her covered with a sheet. And the one behind her neck went from base of her skull down to about T1. So the low back hypothesis for the facet injury: why would you end up with low back pain if you got hit in the neck with a picture frame? Why would her low back hurt? Well, if you think about being bent forward at the waist at the time of impact, okay? She's bent forward at the waist. And when the neck was hit, if you look at the force vectors and how your body's going to respond, you drive your neck down, your low back is going to be jammed instantaneously into extension to absorb and accommodate for the impact up in the neck. So my idea was that jam the L5S1 facet, possibly the SI joint, but the neck was much more of concern, and her concussion was concerned. She had concussion was obvious. She had clouded sensorium. She looked dazed. She looked gray. It would have been nice to have the time to do a concussion evaluation and a quick concussion questionnaire, but I only had an hour, and I just mostly wanted her to get better. So on the low back unit, I ran the concussion protocol first, and as soon as that was finished, I went to the pain section. I ran facet joint pain acute, and that starts with 18 and 62. So you wanted to stop the bleeding in the low back, and I figured that 18 and 62 run on the facets in the low back would also influence the neck, okay? Because at 24 hours, she's still going to have some leaking. So the neck treatment, all of this was done alternating. I had no MRI. I had no way of evaluating the spinal cord or the disc integrity in her neck. So everything was run alternating. I didn't polarize anything. So the first thing I did with her neck was 18 and 62. Injury was 24 hours old, little less than that actually, and just wanted to make sure that we'd taken care of the bleeding if that was something that was relevant, and it was. So that basically made her stop blinking. And the neck muscles softened. She didn't fall asleep for that, but she just, everything got soft. It was pleasant. It was nice. It ran for maybe 5 or 6 minutes. And then all of the pain and the clouded sensorium and the feeling of fragility, of being fragile, of walking carefully, and just her whole body language said to me that she was a 40 and 10 patient, right? That her spinal cord was inflamed. She had these hyperactive patellar reflexes. And I mostly wanted to take care of the spinal cord. So I ran 40 and 10, alternating back to front across the neck. Fell soundly asleep. That frequency ran for 15 or 20 minutes. And then, so the damage to the spinal cord, why was the spinal cord inflamed? Well, there's a couple of things. If the picture frame hit the C6 spinous process, and it did, it would shove the whole segment forward. So she may still have lax ligaments, but it would shove this segment forward and could have like physically bruised the spinal cord or traumatized it. It could have bulged a disc and made the spinal cord inflamed indirectly because of the disc material. So the inflammation in the cord could come from direct trauma, or secondarily from the disc, or just generally from just the inflammatory products that are released just by the trauma. So 40 and 10, and that's the part where you just be quiet. It's like watching grass grow, right? You just wait until she wakes up. So it was about 20 minutes, I think, when she finally sort of roused herself a bit, blinked a couple of times, at which point I ran 40 and 710. The disc annulus, and knocked her out again. So she fell asleep. That pointed me toward the disc complex as a problem. So, and that eliminated her mid-scapular pain. It took it about 10 minutes, but at the end of 10 minutes, I asked her how the pain in between her shoulder blades was, and she said, with a slightly slurred voice, she said, yeah, it's gone, good. So then I ran 40 and 630, which the disc as a whole, and 330, the disc nucleus. It was comforting that both of those didn't do much, right? They didn't run very long, didn't make things that squishy. It was nice to know that the disc as a whole was not too bad, and the disc nucleus was not that involved. So it's just the annulus. So that was comforting. And then 40 and 396 helped with, so inflammation in the nerve. That helped with the muscle tone, especially in the front, and the paraspinals. 124, torn and broken. Oh, yeah. 124, torn and broken in the disc annulus, and that kept her asleep. So she was out for close to 50 minutes, and what I had to go by was softening, just tissue softening. You could feel it in her arm, but I had my hand up on her neck. I was sitting next to her. She was supine on the table, much like this photograph is. So I ran 124, torn and broken in the disc annulus, and that ran for probably 5 or 6 minutes before it stopped doing anything. Torn and broken in the connective tissue, 77. And that ran, I would say, for another 6 or 7 minutes before the softening became less profound. And then 124 in the ligaments produced a lot of softening. And that was fun. So, and then I did inflammation in the cartilage, because when you look at the picture here, what happened, if you look at the spinous process, where it got smacked, it's going to jam the cartilage. So there's a joint capsule here, and the cartilage is the part of the bone, part of the facet joint that produces most of the splinting and inflammation. So I ran inflammation in the cartilage, inflammation in the joint capsule, but that didn't actually do much. And by that point, all of the muscles in her neck were so soft. I reached around the back where the little laceration was, and it was soft enough that I could palpate the periosteum. And I asked her how that felt. She jumped, it hurt. And so I ran 40 and 783, and it became non-tender in about 20 seconds, actually. But the muscles around it were softening, so I ran 40 and 783, the periosteum. And then I did 124 and 783. And that made the muscles even softer, and it made the periosteum much less tender. And in this particular case, if you think about it, and go back to the picture, this is a very thin layer of bone. So to have a delicate sort of bone bruise here that would affect the bone, 59 and 39, would not be completely out of the realm of possibility. So I ran 124 and 40 with 783. That produced the most profound change in symptoms. 59 and 39 didn't do much, so it didn't cost me but like 30 seconds or a minute to run by them with 124 and 40, okay? 60 minutes treatment, and we were pretty much done. So the outcome, what was really fun was the clearing of the concussion. Her cognition was cleared. She was pink instead of gray. Her eyes were bright. She didn't have them sort of hooded to keep out the light. She was no longer, she didn't complain of being light sensitive, but then I didn't ask her. It was so obvious. She just, the light was hard on her. Her pain was completely gone. Range of motion was full and pain-free. Her low back on the left was still slightly sore with extension. So in a perfect world, I would have seen her the next week. And I suggested that they keep arnica on the low back. And then I told her practitioner that if she developed arm pain or leg pain, that they needed to get an MRI of the C-spine. So what I would be looking for, and flexion extension x-rays of the C-spine, right? Within about 2 weeks, the soft tissue is going to heal, so you're going to have enough range of motion that you can take a decent flexion extension film. And if she gets all better and there's no peripheral symptoms, yay, we fixed it. Awesome. Aware and follow up the next week. Or yeah, I would follow up the next week. So following up with, well, I would say in 1 to 2 weeks. Following up with flexion extension film, x-rays, plain films. And then if she develops any further peripheral symptoms, if that zing down her leg turns into a dull ache and there's tightness, that's worth pursuing. Is there a disc? Is there cord compression? Has there been some sort of myelopathic damage to the spinal cord? So what I'm writing in here on the slide, so MRI of the neck, if there's long track signs in the legs or arm pain, right? Any loss of grip strength, anything like that. So just because we were able to fix it doesn't mean that it's finished, right? The fact that 18 and 62 ran for so long and created so much softening gives you an idea that bruising the spinal cord is a distinct possibility. that we just don't know what's going on. So you can use the frequency effects to tell you what was injured. It cleared her pain up. The question is she going to stay pain-free? Is her range of motion going to remain pain-free? And what else is going to develop? And you won't know for another 1 to 2 weeks. So I texted the practitioner and said, how is she doing? And we'll find out. They don't have the ability to do FSM down at that campus yet, but it's very exciting. We're going to be doing, I think, a class down there for the students and faculty at SCNM. I did a fibromyalgia workshop for them. It was just great fun. I haven't done that workshop in about 4 years. And those of you that have seen it, it's 4 to 5 hours of slides, and we did it in 90 minutes. Went over a little bit to maybe 2 hours, but everybody stayed. It was really interesting. What is old news to us when it comes to fibromyalgia, having different types and different causes, was new to them. And the 40 and 10 protocol was, and those patients who recovered, that was a good exposure for them to find some way to treat this very difficult group of patients. And I was really grateful to be able to go to SCNM. If you check our Facebook page, you'll see the pictures from the campus, and yeah, it was a very good time. So that's about what we have for today. If this is a format that you like, talking about how to think through what it is that we're doing, there are more cases that we can do, and every webinar for the practitioners is going to be different. The new person webinar that we do on the same day, only earlier, or that we do at a different time, that's an introductory seminar. You can send your friends to that or your patients to that. It's aimed at practitioners, but it's the introduction to FSM. This format is designed to just give you an idea of how you think through the process, how to evaluate, how to look at it, how to make choices, how to use the frequencies efficiently and effectively to help the patient that's there with you now. The cookbook is a good place to start. Everybody has to start someplace. But my goal for all of you, especially the 85 of you that are still with us, is to help you think through and make your use of FSM more effective, more efficient, more time efficient. These patients were seen in a 50-minute hour and had quite a good start on a recovery. I want to take a moment to remind you about the advanced course. March 29th is a practicum instructor training. Our goal with FSM is to get the course seminar on the internet as modules, to do it primarily to distance. Truth to be told, I'm 70 years old, and we have to figure out a way to preserve the information and to get it out to more people. So we'll do more and more distance learning and the internet modules and the textbook. And we need practicum instructors to teach people how to use their hands, how to feel the tissue changing, and how to kind of make decisions about how to use the frequencies and how to go through the basic practicums. So that's what we do on that day. It's a different training. It doesn't teach you how to use FSM. It teaches you how to teach. The advanced seminar is one I'm really excited about. It's March 30th and 31st. It's a Thursday, Friday this year because we have a symposium on Saturday, Sunday. I do my thing in the morning, all the new frequencies, and I'm actually rewriting the slides this year for those of you that have gotten tired of the way I've done it in the past. Our morning courses are going to be, Paris Carbat is going to do integrating frequency-specific microcurrent into a functional medicine practice. She is one of the functional medicine doctors at Cleveland Clinic, and she has now got permission to use FSM as part of her treatment strategies. So she's going to do a 3-hour segment while I'm talking for those of you that have functional medicine practices and are looking for ways to implement FSM within that treatment paradigm and within that business model. And Kim Pittis is going to do 3 hours in sports medicine while I'm giving my morning workshop. So you have a functional medicine 3-hour segment in the morning on one day and a sports medicine, physical medicine workshop on the next day. The expert workshops or faculty this year is very exciting. I have Neil Nathan, who is biotoxic illness, mold, and the gut, as I recall. Don't have it in front of me. Simon Yu is one of the nation's experts in parasites, and Simon will talk about how to integrate treatments of parasites with FSM, how to use FSM within that treatment paradigm. He and Neil both are quite expert at what they do. Other faculty members you can find on the postcard that went out because my mind just went blank. But we have quite a list of expert faculty at the advanced on the 30th and 31st. And the consumer book, The Resonance Effect, we got behind by about a month because of some other time commitments that I had. Cliff Spohr, right, Rob DiMartino. Diana Cross is going to be speaking at the symposium. Roger Billica is going to be emceeing the symposium. Anyway, so back to the Resonance Effect. We hope to have it available by the advanced and symposium, but there was a deadline that got missed. So it's going to be released on April 24th. So about 3 weeks after the symposium is over, but we'll take pre-orders, and I think we'll probably do discounts on people that buy copies. The book is only $14.95. It's $15. It's published by North Atlantic Books, which is a subsidiary of Penguin and Random House. And so we hope you buy multiple copies and give them to your patients or sell them to your patients, sell them in your office to explain. The Resonance Effect explains how FSM came to be, how it was developed, and all the things it's good for. It's quite a fun read. From Jim Oshman called it a page turner. Then April 1st and 2nd is the symposium. The symposium has always been 1.5 days. This is our 20-year anniversary. Think about that. We've been doing this for 20 years. So I want to make this quite heavy with practitioner case reports. David Musnick is going to do case reports in tendinopathies. Diana Cross is going to come and talk about further developments in her exploration of the mechanisms of FSM. Jim Oshman is back with us again, and Roger Billica is the MC, which gets me off the hook and gets you somebody with a sense of humor behind the microphone. So I'm pretty excited about having that. Of course, there's the banquet on Saturday night where we're going to do the Ruth Johnston Award and probably the LEAP Award again. Any practitioners who have cases to present, it's a 15-minute or 30-minute slot. So it's any place between 10 slides and 30 slides. And the cases that you take for granted, they don't have to be spectacular. They just have to be successful. What did you do that worked in a patient that was very difficult, or even just moderately difficult, or just unusual? That's what we need for the symposium, and I'm looking for 10 or 15 practitioners. The good news is you get the symposium for free. We pay a small honorarium that's probably not what you deserve, but you get the symposium for free. And I'm really excited about this year's symposium. And the truth, not to beat this drum overly, but the truth to be told, I'm 70. I plan to live forever, but there's no guarantees. And after 20 years of doing this, you never know which one is going to be the last one we do. So I encourage you to make an effort. The rooms at the Green Valley Ranch Resort are only $150 a night. The resort is gorgeous. Unlike our other Las Vegas venues, Green Valley Ranch is right in the middle of everything in Henderson, middle of the everything in Henderson. It's not the Strip. There's a Whole Foods across the street, and there are probably 25 or 30 restaurants within walking distance. It is a gorgeous facility, and I'm really pleased to be able to offer it to you for this event. So I guess it's 3 o'clock. I know we started a bit late, but this gives me some time for questions for those of you that have them. And we'll just we're going to end with what we do. Basically, you, all of you, are changing medicine, treating patients one day at a time, one patient at a time. And every patient's life that you changes the patient's world, changes our world. I'm incredibly grateful for all of you that are out there doing FSM and bringing the benefits to your patients. And I hope to see you at the symposium. We'll have the discounts on the rooms. You get 20% off the advanced seminar when you bundle it with the symposium before December 31st. And our room block expires, I think, in January, so February, right? 30 days before the symposium, we have to release the rooms. So be sure and call the hotel or book it online. And I'll see you in March. So we have room for questions. Do we want to stop the broadcast, or are we going to take questions?
It doesn't look like any questions are coming in.
I don't see any questions coming in.
If you have any questions, definitely email us.
There's still people listening. So hi, everybody. We have, no questions that are coming in as far as I can see. Let me see if we got them down here.
Everybody else was just trying to figure out if we were getting started.
Webinar. Yeah, sorry. Everybody noticed we were late. Sorry. Not able to contact. Oh, and the, okay. Oh, there it is. Okay. Slides are fuzzy. Sorry about the slides. Encapsulated toxin frequencies work with diverticulosis. Diverticulosis, not so much. I use prolapse with that, 139, 124, diverticulitis. Diverticulitis is pretty serious, so you really want to make sure that the patient is, if the patient is on antibiotics, so you're going to be doing conservative care with them, as well as FSM, probiotics, Saccharomyces for diverticulitis, or OSIS, and broken, and do what you can to reinforce the connective tissue in the gut wall. Not related. Patient has sudden onset of laryngitis, paralysis of the right vocal cord. Yeah, vagal nerve doesn't innervate the vocal cords as far as I know. That's really an interesting, maybe viral. I'd treat the nerve, like from the back to the vocal cords. It's not the vagus, is it central? I don't remember what innervates it. The vocal cord frequency is 55, so maybe torn and broken. Why just the right one? What happened? So Roy, I guess the question is, what caused it, right? To get an idea about how to treat it. Hi, Marilyn. Happy holidays. Axel asks in Germany, when am I coming back? And Heinz is having a course seminar at the beginning of May. Check the website. And then we will do an advanced in Germany that's just me and practitioner case reports. So I'm going to hit you up for a case report, Axel, in November when I go back. I'm pretty excited about that. And Mylene, how nice to hear from you. Happy holidays to you and to everybody who's listening. Okay, Roy thinks it's a vocal cord. It's a virus. So the virus frequency that works the best is 160. And so I guess 160 in the vocal cord, 160 and 55, 160 in the nerve, 396. Yeah, sorry we started late. God, innervated vagus to the right laryngeal nerve. Well, there you go. I learned something. Thanks, Roy. Thought process for chronic abdominal pain from stomach ulcers and GERD. They need to get off of gluten. They need to go on a grain-free diet and probably eggs and milk as well, because it's probably allergenic. Until you've done that, and probiotics, not so much. Spasmodic dysphonia, maybe on the vocal cord issue. Could be viral, could be central. So, oh, sleep apnea. Thought process for sleep apnea is a CPAP and a sleep study. Sleep apnea is a fatal condition. I don't mess with it. I don't treat it with, I don't treat it with FSM aside from running the concussion protocol. If you read The Promise of Sleep by William Dement, he will convince you in those 400 or 500 pages that that sleep apnea is a fatal condition. Doesn't matter what else you have, sleep apnea is what you will die of. So a patient with sleep apnea gets a sleep study and a CPAP, or they get fired. If they're going to die, they're going to die on somebody else's shift, not mine. So I'm not even nice when it comes to sleep apnea. You know how you usually want to not scare people and you want to kind of not concern them overly about what's going on with them. With sleep apnea, people take it for granted and they underestimate how dangerous it is. So I do my best to scare the hell out of them enough that they will go get the sleep study and go through the inconvenience of having a CPAP. So there you go. I think that's it. Thank you very much for sticking around. It's great to talk to you. I hope all 60 of you come to Las Vegas. This is a banner year for us, for any unique technique, novel technique, especially resonance-based and frequency-based, for any novel technique to survive for 20 years is a credit to you and what you do in your practices and all the patients that you've helped, and for all the support you give me and the FSM staff. And there you go. Okay. Happy holidays, Merry Christmas, happy whatever. And we will talk to you in January. And thanks so much to Kevin Green for fixing it so that I get to do webinars. This is really fun. Thanks, guys. Bye.